Dr. Maji, thank you very much for your kind introduction. You are so kind and gentlemen. So the topic today is peeling of PVR membranes. So as we know, PVR complicates about 5 to 10% of all RD surgeries, but can be seen without a previous surgery. The source of cells is RPE or glial cells. The latest classification is from 1991. It talks about the location of PVR and the type. So posterior PVRs would be either focal or diffuse or subretinal. And anterior PVR, there are two types, circumferential. Just look at the picture on the right. So the anterior retina is smooth and the posterior retina will have folds and anterior displacement. So the risk factors, we all know anything that causes inflammation, such as large breaks, multiple breaks, vitreous hemorrhage, excessive cryo laser, and postoperatively. PVR surgery, if possible, try to wait about 6 to 12 weeks, but you have to balance the duration of macular detachment. Usually buccal is helpful, so if they don't have a buccal, they should have a buccal. Most of these eyes will have silicone oil or long-term tamponade, so if they are phakic, try to make them pseudophakic a few days before. Do a complete PPV. These membranes are thick and adherent, so you have to be patient, and you may have to do bimanual if needed. So peeling, you always start from the posterior pole first and operate under oil if possible, because the oil improves visibility of membranes and keeps the retina stable. Anterior PVR, you have to break and remove the ring of cortical vitreous the best you can, and the buccal. And if there is a peripheral gutter or anterior displacement, you have to open it. So this is an essential technique. You have a thick membrane, so what you do, you just grab on top with the forceps, and then gently apply traction tangentially, and very soon it's going to come off. And I can just advance it a little bit. And here it comes. So there is no need to use picks because they damage the retina, and you can create a lot of damage. So just stay on top and gently peel it. So let's look at some situations. There is no previous vitrectomy, and you have PVR. So this is a standard technique in PVR. You start from posterior. You do a complete vitrectomy the best you can, and you try to peel. So another name for PVR is hypocellular contraction. So the vitreous itself doesn't have much cells, but there is a lot of traction force being exerted. And you just keep peeling, keep peeling. Once you have done posterior peel, put perfluoron, and the peeling continues from posterior to anterior direction. And this is fluid exchange. Keep perfluoron away from the breaks, and you are done. So sometimes you try the same technique, but it's not possible to peel. So in these cases, you apply some PFO. So this is vitrectomy. This is being done. And then you're trying to peel. Nothing works. So no worries. It doesn't work, so put some perfluoron. And now the whole case becomes very, very easy. Now you can grab it, peel it. But you have to be careful, because if you create a break, perfluoron might enter under the subretinal space. But with practice, it's actually quite easy. And here you go. Just notice tangential traction, and don't pull straight in. So posterior PVR in a silicone-filled eye, these are actually very easy cases. So don't remove silicone oil. Just grab the membrane on top, gently peel it. Keep silicone oil in. And after that, just go into the hole. Two-pole technique, as Dr. Charles described. Retina is flat, apply laser, you are done. Now this can be a little bit tricky. This is anterior PVR, and the patient had silicone oil, so you remove silicone oil. You try to open the peripheral gutter the best you can with the vitrector first. And after some time, vitrector will not work because they are too fibrosed. And then at this time, you use scissors. You open it the best you can. And once you have opened it, you may have to use cutter. You can open gutter, the trough quite well. And some part where it doesn't work, you have to excise it. So you have a very small retinectomy, and it looks quite well. This is under air. Subretinal PVR, you find a spot which is convenient to you, which you will as drain retinotomy, apply cautery, and use two hands. In this case, I'm using forceps and light pipe. You pull the membrane and use the other hand to give you counter traction. And you just hand over hand using two hands. This big strand is going to come out. And you are done. So I thought rather than talking about much theory, it's better to look at these situations. And it looks quite well. So that's the area that you used for drain retinotomy. To summarize, learn multiple methods to peel membranes. Peel only what is necessary. Usually these are thick, obvious membranes. You don't need much staining or anything to do. And be patient. Thank you.